Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clanet, serving as a allocated session assistant to ensure a seamless experience. Clanet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as a data partner for this event, jointly hosted by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation USA. And the focus of today's session is LV diastolic function. Now I will play welcome video to welcome you all. Just allow me a moment. Now, I would like to welcome Dr. Muralidhar Kanchi, sir, for the further proceedings. Over to you, sir. Thank you.
Good morning. Thank you so much for the introduction. We are really grateful to the Clinet for providing this service. Rimpa, thank you so much. I would like to welcome all the attendees for this Sunday breakfast session on diastolic function. Very, very important topic which needs to be assessed in patients with cardiac disease and hypertension, etc. This event is being organized under the auspice of Karnataka chapter of IACTA, the Indian Association of Cardiothoracic Surgeons, and Indian College of Anesthesiologists. Additionally, this is supported by the international societies, that is the International Society of Cardiac Ultrasound, the Global Heart Care Foundation, and the Global Intensive Care. And today we have three prominent faculty members to deal with this subject. Dr. Sanjeevani Inamdar is from Pune. She is very well known in the cardiac anesthesia and echocardiography circles. And I would like to point out that she is one of the few cardiac anesthesiologists who is equally adept in transthoracic as well as transesophageal. And I would say that she is very talented in the sense that she can correlate TEE, the disease pattern, and the transthoracic echocardiographic findings. Dr. Arun Andappan is from Raipur. He is again a talented and accomplished cardiac anesthesiologist. And Puneeth is my colleague in Narayan Hudyalia. He is again a committed and talented cardiac anesthesiologist with great experience. With that, I would like to request Arun and Puneeth to take over and conduct the session. I request all the participants to keep the mics muted, excepting for the speakers and the moderator till the end. And the questions and opinions and comments can be posted on the chat box. We'll get back to you at the end of the session. And I request Sanjeevani to provide at least 15 minutes of discussion time so that we can clarify and clear our, I mean, the whatever clarification we need to do, or if there's any additional point to be added, which is important, that can be done during that time. With that, I request Arun and Puneeth to take over and do the session. Thank you.
Thank you, sir, for the kind introduction. This is a very important topic that we are going to deal with today. And as we all know that fluid management during cardiac surgery or non-cardiac surgery is quite important. And obviously, T or TT is going to help us perform that very well with the help of these measurements. But unfortunately, these measurements are not very commonly done because in cardiac surgery we do have hesitation because like we see the heart directly inside in front of us, but then fail to do the measurements at all. And similarly, we go by certain other measurements like CVP, but as part of focus and as well as these measurements, it's very important so that you can give the correct amount of fluid without ending up in or or initiate dialysis therapy where there is already an established fluid overload. So over to you, ma'am, for the talk.
Should I share my screen, Randy? Are you able to see my screen? Rajiv?
Yes, ma'am. Yes, ma'am. It is visible. Make it a full screen, ma'am.
Yeah,
Yes.
we can see it. Please go ahead.
Yeah. So as Arun said, this is a very, very important topic. Everyone must know this, and one has to do it before operation. That is also, I will be telling you again and again that this has to be addressed on transthoracic echo because it is not that validated under operative conditions. So there are no disclosures. Few slides are taken from the net as they are allowed, and most of the images are my own. So this is popularly diastolic heart failure is known as heart failure with preserved ejection fraction. That is popularly pronounced as HEPF. And it is an iceberg of heart failure problem. Whatever we are seeing is just the tip of the iceberg. Incidence is more than 50% of all heart failure patients. Mortality and morbidity is at par with heart failure with reduced ejection fraction, known as HEPREF, now recognized as an independent predictor of adverse cardiovascular events, and all vulnerable patients must be with dyspnea must be evaluated for diastolic dysfunction. So I will be dealing this topic under these headings. So let's start with introduction, and here I will speak on ventricular diastolic tracings and its components, sucker and pusher effect, and certain laws of cardiology with respect to systolic and diastolic dysfunction. So we all know this image since our MBBS days, and very important, one has to, um, you have to print this in your brain that this is LV and LA diastolic pressures in diastole, and this is E and A are the mitral inflow flow during diastole when the mitral valve is open. So these Nishimura, since 1996, they have been, proving that echo parameters are at par with catheter parameters. They proved it, and there is no need to do catheter for diastolic dysfunction assessment. So this is the simultaneous pressure tracing of LV and LA in diastole. I would request all of you students to understand this diastology, and then though it is a difficult topic, you will find it easier to analyze it while you are managing the case. So try to understand this. This is very important. This is LV relaxation slope. then followed by sharp initial dip. We all know this, just I'm trying to rebrush your memories. This is sucker action. Then this is diastasis, almost no flow. Again, LV stiffness and compliance decide this slope of diastolic pressure, and this is end diastolic pressure. LVEDP, the most important word in diastology is LVEDP, and then LAP. So this is early diastolic gradient between LV and LA. There is sucker effect prominently and little pushing effect by LA, which is causing E wave on echo. So what is diastolic dysfunction? It is the elevated LVDP with normal EF and normal LV volume. That is most important, because in systolic failure, the volume is more, and that equates to diastolic dysfunction. And how do we measure it actually? So the cursor is kept at the annulus of the mitral valve to know the tissue movement. That is this LV relaxation slope. And as it is shown over here, that this LV is sucking the blood. So majority, it is this sucker effect. And this is also known as E prime. Now the guidelines have changed, and I will tell you as we go what is the exact number for this. This is E prime at lateral wall, then it is E prime at medial septum. And another important is how we measure tissue movement. In the same way, we have to measure blood movement during diastole. So the cursor is kept at the tip of the mitral valve, and it is known as atrial wave, E wave, not atrial wave, which is followed by A wave, and normally E by A is more than 1 and less than 2. So this is how I have shown you this. But as the disease progresses and ventricle starts becoming thicker and thicker, there is raised LA pressure. You can see this is LA pressure over here. Now it has raised considerably, and then it is grade 3 diastolic dysfunction with predominantly pusher effect, where E by A is more than 2. And then E is very tall, deceleration time is less. This is how we try to remember the pattern. Pattern is also very important. With that pattern also, you can diagnose many things over here. So the golden ratio in echocardiography in diastology is E by A prime. E is the function of LA pressure and LV relaxation. We know that is blood velocity, and E prime is LV relaxation. So E by E prime equates LA pressure, and typically when it is more than 14 average, it is raised LAP. So people have proved this is in 2000. How powerful is this non-invasive method to diagnose feeling pressure? So they have proved it by doing catheter studies. So this is E by E prime with LV feeling pressure. Now, if one has to look at this, and this is the most important slide of my presentation, please pay attention and just follow the animation. Just follow it. Just look at it, how I'm progressing. So green arrow is normal and black are abnormal. Then when it is LV stiffness, again, green is normal, yellow is mildly increased, and red is severely increased. And most important is elevated LA pressure. That is what we are concerned about, whether patient is having elevated LAP or not, and that's how the whole management changes. So one has to know whether LAP is raised or not, and this is how it becomes more and more as the disease progresses. So we know that this is the sucker effect. Normally, this is the pusher effect. Young patients fall in this, old people fall in this, and this grade 1 is known as compensated diastolic dysfunction with normal LAP or PCWP at rest, but raised LAP and raised EA ratio during exercise or tachycardia, which we cause during surgery. So we can push this patient to 2 or 3. So that is why one has to understand this very thoroughly. So they have again correlated echo parameters with hemodynamics and proved that how IVRT and rapid filling, diastasis, and atrial contraction, they all correlate with catheter events. And this is in one image how diastology progresses from normal to grade 1. DT is prolonged, then E has started rising up, DT is prolonged again, and then suddenly DT, that is deceleration time, reduces because LAP is too high. At the same time, E prime has started reducing. So again, this is the people have correlated it with LV pressure and LA pressure tracing along with the echo parameters. And this person in 2017, Anderson, he found this patient with grade 3, TR velocity more than 2.4, E and A more than 2, and LA volume more than 34 ml per meter square. These are all parameters. I'll come to that in a short while. And E by E prime is 21. And when this patient, he did catheter studies and proved that PCWP was very high. So people have worked so much on this. Again, the same thing with color, beautiful color flow. How if we give fluid, it goes to grade 3, and if when we give diuretics, it goes to grade 2 or normal LAP. Nagesh has shown this beautifully in this image. This is again the same thing at one glance. I will just let you know as we go on. So how do we grade diastolic dysfunction? Simple. Remember this. Impaired relaxation with normal LAP. That is grade 1. Grade 2 is impaired relaxation with high LA pressure. And grade 3 is very high LA pressure. So try to, in your brain, simplify this topic as much as possible. So Anderson, he told us to do mitral E velocity, septal E prime and lateral E prime, TR velocity, and LA volume index. I'm not going to speak on this, LA, how to calculate LA volume. It's given everywhere. What is important is LA volume and prediction of heart failure. They correlate very much. E by E prime and LA pressure also correlate. I have been telling this. And even deceleration time is can predict the events or event-free survival in this graph. So how powerful again is this non-invasive method? So, but how do we get TR and how does this happen? Why patient become breathless? So when LAP is increased, this is a closed compact fluid system of heart. So as LAP increase, there is pressure on pulmonary vasculature, there is increased PAWP, then there is TR, and then there is RV volume and pressure overload. So what happens to chronically raised LA pressure? LA volume is increased, pulmonary hypertension occurs, RV diastolic volume pressure overload, increase in TR velocity, and last but not the least is atrial functional MR. And this MR is different from your ischemic heart MR because this is central due to elongation of the annular ring of mitral valves. So these are the echo pictures of the same. Why it is important to know MR? Because it is popularly known as AFMR. Because severity of MR increases mortality and heart failure readmissions. See, until this we have seen how one can go to diagnose diastolic dysfunction, but it is not that easy. There are many things that are not, we cannot address them. There is a mixture of pictures. So there are other useful parameters. You should take help of that. And one of them, important one, is pulmonary vein pulse wave velocity. It should be like this normally, and when S is less than D, it is raised LP. At the same time, E deceleration is also important. When it is less than 150, it is raised LFP. Simply, it means that L and LV pressure are so high that they equate very early. That is why it is tall and short E wave. Another useful parameter is L wave. See, usually in diastasis, there is no flow, not supposed to have any flow. But because of raised LAP, there is L wave. Of course, it should be more than 20s. Nowadays, they are saying more than 40 to label it as raised LAP. And this is M mode transthoracic echo, M mode in plaques view, where you see this typical M and W of mitral valve. And when you see one bump on the downside of A wave, that is end LV diastole, you see this bump that is due to raised LVDP. And this is the normal picture of mitral valve in M mode. And this is how the B bump is seen. So this is, please students, pay attention to my lecture. I would ask you which is the other parameter for raised LVDP. You will get the answer if you listen to this lecture carefully. Okay. And Valsalva maneuver is also another very useful parameter. I am doing this almost every day in many hypertensive patients. See, when you get this type of picture, it is certainly not grade 1. So, grade 1 is E by A less than 0.8. But a patient is hypertensive, elderly, he's complaining of breathlessness. So clinical judgment, clinical correlation is very important. You ask him to do Valsalva, reduce his LAP by doing that, and you will get this typical grade 1 picture. So this is certainly a grade 2 diastolic dysfunction. Here also I have shown you the same, that how E is more than A, and after Valsalva, E is less than A by 0.5. That is the cutoff point. And when you see diastolic MR, you know there is tremendous rise in LVDP, LV is failing, you do get diastolic MR, and that is a sign of raised LAP as well as raised LVDP. Another important parameter is IVRT, isovolumic relaxation time. See, it has to be between 70 to 90, but when it is less than 70, that simply means that mitral valve is getting opened fast because LAP is raised. So very simple. So IVRT is a very useful parameter. One has to do it every day. Then only you will understand it. Velocity, propagation velocity of blood in LV during diastole. So this velocity people have measured this, and it has to be more than 50. That means the ventricle is relaxing well. It is a rough measure, and one should not use this as a solo parameter to diagnose, but one has to divide it. E should be divided by VP. When it is more than 2.5, PCWP is more than 15. So this is how it is taken. This is normal and this is abnormal. It starts looking slanting. That means blood is getting resistance to go inside the LV. This is another question. What mistake I have done here and which image is the right one? Please see, if you want to take screenshot and later on answer this question. So in 1993, you know, people have compared A duration of mitral inflow and AR duration of pulmonary vein. And they have compared, and when it is increased, they have proved that there is raised LAP and raised LV pressure. So this is popularly known as AR A duration or MPV and APV duration. It should, when it is more than 30 millisecond, this is raised LVDP, and it is very useful in HOCM. Why? Because HOCM usually doesn't show S and D parameters of pulmonary vein. So this is pulmonary vein parameter, and where in 4-chamber it is taken at the deep inside the pulmonary vein, and you get this systolic wave, diastolic wave, and aortic and atrial regurg, atrial kick, and you have to measure. See what is the physiology behind this. Usually, these two waves come due to atrial contraction, and they occur at the same time. So naturally, some blood is thrown into LV and some is thrown into pulmonary vein, because pulmonary vein is another outlet for LA blood. Okay, so whenever LV is having more pressure, naturally more blood will go into pulmonary vein, and that is why this duration is increased. And this is the earliest sign of diastolic dysfunction. Very useful, very useful, and very simple to do too. So this is intra-op scenario. Few days back, I did this just to show you. This is left superior pulmonary vein, and this is the pulmonary vein profile. This is mitral inflow, and then this patient has normal APV and AMV. This patient was CABG and with normal LVADP. So I was relaxed. You become relaxed when you do this during surgery. And this is to show you how in transesophageal one can do E prime as well as mitral inflow. But mind well, these are not validated, these guidelines for intraoperative scenario. I will talk about it later on. But there are many pitfalls also. Whenever patient is having aortic regurgitation, you just cannot, place your cursor on mitral inflow because the regurgitant flow keeps coming. Again, in aortic regurg, there is TR and LA due to obvious reasons, so it is really difficult to address diastology in TR. Again, whenever there is short diastolic time due to heart block or bundle branch block, analysis of this diastology is very difficult. In atrial fibrillation, there is absent A wave, so there is no question of E and A. But what one can address is E by E prime more than 11. Usually it is 14, but in AF, it is more than 11 is the cutoff point. E wave dt less than 160, peak acceleration rate of mitral E wave 1900. I have not done this. IVRT less than 65, yes. Pulmonary vein D wave dt less than 220, very easy to do, very easy to do. And E velocity and mitral VP instead of 2.5 in atrial fibrillation, the cutoff point is 1.4 to diagnose it as raised LAP. One has to all the time think whether LAP is raised or not. That is the main crux of the matter over here. So this is actually my case. I was very happy to get this mitral annular calcification in this patient, and in these patients also E prime is already reduced. So E also is not very, you cannot get a good E wave also. So very difficult to diagnose diastolic grading in these patients. We'll talk about these certain laws in cardiology, certain different graphs. So this is our simple uh, this law. I just forgot its name. What is it, Muralidhar?
It is Frank Starling.
Starling's law. I got nominal block. So this is a volume against cardiac output, and this is the normal and systolic heart failure. Flattish wave. You all know this. And this is again afterload and stroke volume, and how afterload reduction as well as preload can be tolerated in systolic heart failure. That is what we wanted to stress upon your mind with this graph. So let me reiterate that how systolic heart failure differs from diastolic. It has impaired contractility, reduced ejection fraction, low stroke volume, LV progressively dilates, causing still more afterload. But if afterload is reduced, it can behave normally. So afterload dependent, and it can tolerate both pre and afterload reduction. I just show you these two graphs. So diastolic heart failure is very different and difficult to manage. There is slow relaxation. There is steep LV pressure volume curve, which I will show you in the next slide. It is more preload dependent. Sometimes you have to give fluid in initial stages, grade 1. And after load and preload reduction, there is a very narrow therapeutic window. They are very sensitive. So this is what I mean to say by that this is the diastolic dysfunction curve, steep, this is normal, and this is systolic dysfunction. So preload reduction won't be tolerated in at least initial stages because of the thick ventricle ahead. So LA cannot push, so you have to give little fluid only in the initial stages. So accept little high PCWP. So how do you manage and how do you try to make them come to normal during surgery or otherwise? You use mild afterload reduction. Okay, trophic drugs. This is another concept that this is grade 1 diastolic dysfunction, this is grade 3. There is small e, we know, A is large. And slowing up, if patient is having tachycardia over here, slowing of heart rate improves LV filling as it allows more E and A flow. So you can reduce heart rate over here because there is lot of blood still remaining and LA is okay, not that sick. But in grade 3, LA is sick. There is tall E wave due to high LA pressure, narrow E wave due to quick LA-LV pressure equalization. I just told you that. And atria are sick, so they cannot push against the high diastolic pressure of LV. So if this patient, this is very important, if this patient is having tachycardia, don't try to reduce it because it is required for cardiac output. You accept at least up to 120, 110, 130. Then how do you manage these cases? You give diuresis and afterload reduction. So this is the systolic heart failure heart, big volume. And this is diastolic heart failure heart. Hardly any chink is left over here, very low stroke volume in these patients. So these are again different grades. I told you E less than A, more than 0.8, less the E than A. This is one patient with acute MI. I'm trying to tell you in which patients you can see this. This is amyloidosis with LVH grade 3, E by A more than 2. And this is patient with severely low ejection fraction and E by A more than 2 and TR velocity more than 2.8. That is the cutoff point. So this is the heart of systolic heart failure. Remember these, images. That's very important. Our brain captures this and keeps it in its drawer. So this is how it looks. Hardly it is beating. The same thing with in 4-chamber. This is 4-chamber of apical transthoracic echo, severe MR and severe TR. And this is how we get severe TR, reduce E prime, septal as well as lateral in this systolic. Even systolic heart failure has some diastolic heart failure. Coming to diastolic heart failure, look at this heart, severely thickened. This is transthoracic plaques view, this is transthoracic short axis view, this is transesophageal view. Somehow this image is not running. So this is how it looks. So the moment you look at this type of hearts, you know that there is diastolic dysfunction going to be there. So this is E by A more than A, normal. Again, we'll just reiterate E by A less than 0.8, E by A more than 2, grade 3 diastolic dysfunction. This is tissue Doppler, this is normal E. And this E by E more than 14, of course, severely decompensated heart. So clinical feature is not at all very specific. Dyspnea, congestion, edema, pedal edema, fatigue. So it is really difficult. So one has to again look at the Doppler and match the symptoms. So grade 1 or 2 exertional dyspnea and grade 3 and 2 with a little more raised LAP, dyspnea at rest. One has to differentiate these two before surgery. And causes are absolutely abnormal systolic function always has some diastolic dysfunction, decrease EF, pathological LV hypertrophy due to many reasons. All these can cause, so this is very common. So many patients are having all these. So there are many causes, but the most common are hypertension and systolic dysfunction. And don't forget sleep apnea. It is very common even in young patients nowadays. And what is everyone is worried all over the world is now this diastolic dysfunction has started getting affected in young population. That is a very worrisome scenario. So these are 2016 guidelines. I'm not going to teach you this because you can address it anytime. And anyway, it has changed a bit in 2025. I'll let you know about it. So this is with reduced ejection fraction, very complicated and big chunk of indeterminate group is here. So it is really difficult to diagnose it. So let's see few reports, echo report. That is also very important. This patient, this person, whoever has done echo has written, I have purposely taken this to not to criticize anyone, but to learn from it, that this is severe LV systolic dysfunction, LVF 30%, and no diastolic dysfunction. It just cannot be. When we did his echo, its E by E prime was more than 14, EA more than 2. Obviously, he was in grade 3. Another patient, chronic hypertension. Okay, nicely written that grade 2 with raised LFP. That is what we want in the echo report. Now again, study this report. This is mild concentric LVH. Okay, fair LV contractile, fine. Mild MR, so MR he has mentioned. Severe tricuspid regurgitation, severe pulmonary hypertension, 70. And it has come to the right heart, that is mildly dilated right heart. But there is no mention of diastolic dysfunction. Of course, there is grade 3 diastolic, grade 2 or 3 diastolic dysfunction with AFMR, TR, PH. So this is what he had. Another important thing you must know is this typical paradoxical U-shaped distribution of diastolic dysfunction. By that I mean that young healthy adult with vigorous LV activity, you can get E by A more than 2, S less than D in hepatic vein, deceleration time less, all mimicking grade 3. So is it grade 3 diastolic dysfunction? You just have to put tissue Doppler. That is why E prime has given tremendous importance in recent guidelines. So you just put tissue Doppler, and if it is normal, he is a normal healthy adult. So I'll just show you a few of my cases. This is normal healthy adult. And look at his E and A, more than 2, almost 2. Okay. And even pulmonary veins, which I addressed at 2 different places. This is fourth chamber and this is, I think, crab view. S is less than D. So one would think that there is a raised LAP, but tissue Doppler was absolutely normal. So no question of labeling him. This is very important. Otherwise, anyone would start treatment towards diastolic dysfunction. This is one lady with pseudo-normal. I just wanted to show you how beautifully this pseudo-normal. When we gave Valsalva, it became grade 1. So, and tissue Doppler is also reduced. So this is a patient with pseudo-normal, that is grade 2. This is elderly women with elderly woman with PTCA, LBBB, and look at her velocity profile, 41. So it helps us, along with other parameters to diagnose diastolic dysfunction. Another patient, I just wanted to show you because in one bit I got grade 1 and next bit I got pseudo-normal. So it is very dynamic. That I wanted to stress upon your mind how dynamic it is. This is another old lady with same thing and showing pulmonary vein, good pulmonary vein. But what I was surprised to see this young lady from IT sector with severe hokum. With Sam, this is her short axis view in parasternal short axis view, PSAX. But luckily she had normal E and A and normal pulmonary and normal LA volume, and but her tissue Doppler did show some abnormalities. So tissue Doppler is very important as compared to E and A. That is what they are saying in 2025. Again, this is the HOCM. What I want to impress upon your mind is S and D of pulmonary vein is not very important, but the difference between AMV and APV, which I told you few slides back, that is very important in HOCM. So this is one of my patients. I was very happy to get this patient, look at this. His A duration is only this is his AR duration 281. Sorry, I should have written AR minus A, and this is A of mitral tip. One has to put it at the tip. That is 134, much more than 30 milliseconds. So tremendously raised LVDP. This patient is of HOCM again. It's very common, it's not rare at all. You see many patients of HOCM. This is another patient of HOCM. Look at his hypertrophy. This is also our patient with SAM. One more question coming for you now. That again the same patient, and I just want you to know what is this. Sorry, I have not written question over here, but okay, the question is in the next slide. Why it is not going? Okay. So this is again with tremendously reduced tissue velocities, the same patient, massive LV hypertrophy. So just wanted to ask you, what is this in RA and RV of this patient of HOCM, where we did ablation, alcohol ablation, and his gradient across LVOT came down from 70 to 14. Why I'm asking you this patient, not related to diastology, but one must know what is this patient clinically. Then only you can assess the diastolic dysfunction. So clinical scenario is very important. So this is my, I think, third question. Okay. The same thing again. Okay, same thing, raise LP, TR velocity. This is the intra-op scenario again. This patient is of CABG and is showing S less than T. So experience and modernity. So this Lisa Thomas, she proved that all these parameters take long time to show. And there is again U-shape distribution. So what is important nowadays is LS strain, which comes quite early. So this single parameter, instead of all these jugglery, if you do LA reservoir strain and if it is less than 18, it tells you that there is raised LAP. It's very simple. So if one has this facility, one should always use this. And what we want to know is whether LAP is raised or not. And the people have proved that LAP is raised, LVDP is raised when LS strain. So it correlates with LVDP. And people have studied so much on LS strain that it is become it has come into the guidelines. Same thing again, strain and filling pressure, and LS strain and PCWP, lot of things. I wanted to tell you about this 2024 British Society of Echo Guidelines. They have tried to reduce this indeterminate chunk. I'm not going to go into detail. You can address this. Only thing is that you should know that they have included LA reservoir strain, AR A duration, L wave, and age specific EPREP that I will show you one slide, and diastolic stress echo. This is when LVF is less than 50. This is when there is atrial fibrillation, when there is pulmonary hypertension, and this is what one should talk about now today, that is LV diastolic grading from ASC 2025. So they have tried to reduce this chunk and they have given age-specific E prime velocity, and it has come down to 6 and 7. 6 for medial and 7 for lateral. Because we were all diagnosing diastolic dysfunction, this has come to age-specific, which I will just show you in a short while. Other things are the same. These three are important things. You should not use this in MAC, atrial fibrillation, and all those things. This is what I mean, that when patient is young, you can use 7 and 10 cutoff points. But when patient is elderly, which is the common scenario now, 6 and 7. 6 is for medial and 7 is for lateral. This is very important. This is from NAGE 2025 ASC guidelines. So these are the important points which they have given, how different it is from previous guidelines. This is another important thing which I liked it. Heavy hypertensive, the heavy means obese, and you can score this patient and then you know that he is going to have diastolic dysfunction. This is again simplification of the same 2025 guideline. Another important, when you don't get TR velocity, what you should see is PR end gradient, end PR. And you add right atrial pressure to it by IVC diameter calculation, and then that gives PCWP. So when TR is not available, guidelines have allowed us to take advantage of this. Coming to our scenario, diastolic dysfunction intraoperative is very difficult. So one has to address this topic before surgery, and during surgery, you can just see the trends. Changing systolic and diastolic function during surgery, changing hemodynamic state. So coming to pre-operative management, one has to um, see whether he is on different drugs due to which he is having diastolic dysfunction. There is specific drug has come now. I have forgotten its name, but I just forgot it. But one can give ACE inhibitor, ARB to improve relaxation, then mild diuretic to reduce preload and reduce congestion. And if there is AF, you have to do rate and rhythm control. But remember, therapeutic window is very narrow than systolic failure. Again, general principles, I have told you this, establish the dominance, that is also not very difficult, adequate sedation and avoid vasoconstriction. Grade 1, you can give little preload, I have told you this, but grade 3, one cannot. On the contrary, you will have to give little diuresis. Again, severe diuresis is harmful. These are important practical tips. Again, for afterload, mild lucitropic drug, isoflurane better than CO, inodilator, dovitamin and milridone. Severe afterload reduction is harmful as against systolic failure management. Again, heart rate, I have told you can give beta blocker in grade 1, no BB in grade 2. You can accept tachycardia up to 120. Rate and rhythm control in atrial fibrillation. So diastolic dysfunction is an important consideration. Echo provides a snapshot of DD, and there is a narrow therapeutic window that renders this treatment very challenging. Thank you, Dr. Murlidhar, for this. Thank you. Okay, should I stop sharing? Okay, Rajiv?
Yes, yes, yes. Thank you so much. It was a lovely talk from the beginning to the end. The most important aspect is that you have connected the cardiological interpretation to anesthesiologist interpretation. It's a combination. It was really good, well done. Thank you so much. And I request Arun and Puneeth to take over and moderate the session in terms of chat box questions, and any comments from anybody else is welcome.
There is one question popped up over here.
Yes, yes.
That LA strain in during operation in TE. Well, LA is not very well seen in TE because we are just behind the LA, isn't it? Our probe is just behind the LA. When someone is very near, you can't see it. So difficult. But LA appendage strain has come and people are doing that. So it should be done before operation.
Sure, sure. Awesome presentation. Thank you so much. Somebody's commented. Arun, are you there? Puneeth?
I'm there, sir. I'm there, sir.
I'm also there, sir.
To comment and
Bhargav
ask any
has come up
questions.
with one question.
There's one more question, sir. How to assess E by A ratio with few
Yes, yes.
D and K waves?
Yes, very good question. When fast A for tachycardia, one should reduce the rate. One should not take as a parameter for diagnosing grading because simply it is all haywire. So either you give, they are saying give carotid massage or try to reduce it, wait for some time because it will fuse, it will not give you proper reading. You have to bring it down. Even for diastolic stress echo, we are not supposed to take the reading when the heart rate is fast. It should be around 100. Then only we can say that E is increased, E prime is reduced, TR is there, like that. Because tachycardia again will exaggerate it, and your intention of diagnosing diastolic dysfunction under diastolic stress echo is otherwise not correct. So we take the patient to the bed, wait for 1 or 2 minutes, ask the person who is looking at the monitor, if pulse rate comes near 100, we take those readings. So that is the way. You have to reduce it at least to 100.
Thank you. Thank you so much.
Hmm.
If a patient with pseudo-normal diastolic function comes for non-cardiac surgery, what are the guidelines? What do you think? How should we manage?
Well, we don't want to push him to grade 3, right? So you have to
Yes, yes.
and you have to see his LAP, how much is his LAP. By pre-operative, of course. During surgery, this is another tip which I follow. Look at the saturation. If saturation is good, the LAP is not raised. It's a very sensitive measure.
Right.
So you have to manage the case like vasodilatation, regional anesthesia, like that. A little fluid going.
One point I would like to say.
Restriction. I would say if it is grade 2, certainly is going to have raised LAP, though not that as severe as grade 3. But you have to restrict fluid of this patient. Don't make it vasoconstricted, keep him warm, give warm IV fluids. So many things we can do.
Right.
See, I have seen.
What is the role of digoxin?
Rolo?
What is the role of digoxin in these patients?
No, digoxin, we don't advise digoxin.
Yeah, it's not needed.
Only
Except
only
if
if
there's
atrial fibrillation, only in atrial fibrillation, not otherwise. Only if you are giving it for atrial fibrillation.
Use it to control the ventricular.
Muralidhar, we didn't hear you. Some disturbance.
Yes.
What did you say?
Yeah. No. Are there any questions in the chat box? I was asking.
How to evaluate diastolic dysfunction in patient with atrial fibrillation?
Any comment?
We have one slide. I told you. See what happens in atrial fibrillation. E is increased. E wave is increased. Muralidhar, we are not.
Yes.
Hello.
Yes, sir.
You can hear me?
Sir, your voice was breaking. Right now, it's fine.
Okay.
Yes, sir, you're audible now.
Sanjeevani, please carry on.
Yes, about this atrial fibrillation and diastolic dysfunction, E by A cutoff point has come down from 14 to 11. For the simple reason, E is increased in AF to compensate for the loss of atrial activity. That is number one. Then DT is reduced less than 150. Then D of DT, deceleration time of D wave of pulmonary vein less than 220. I have one slide about atrial fibrillation and diastolic dysfunction. You have to E by VP more than 1.5. Otherwise, more than 2.5, it gives LAP of 15. But in atrial fibrillation, that cutoff is also come down to E by VP 1.5. If it is more than 1.5, atrial fibrillation patient has raised LAP. So you have to treat him as raised LAP patient. By that I mean give mild analgesics, mild lucitropic, afterload reduction, fluid restriction, all those things. So atrial fibrillation is a common phenomenon in diastolic. They have big LA, they fibrillate. So one has to. And now with yes.
Right. Anybody
Ma'am,
else wants to make it? Yes.
Yeah, I have one question, sir, for ma'am. How useful
Yes.
is it in weaning from cardiopulmonary bypass?
Mm-hmm. Yes, we are not able to hear you, Arun.
How useful are these measurements when we are trying to wean from cardiopulmonary bypass, ma'am?
See, again, I am telling you that during surgery, intraoperatively, these guidelines are not at all useful, but one has to see the trend. You have to see, just see pulmonary vein. Very simple. If it is S is less than D, there is raised LAP. So naturally, you will not come off bypass if there is raised LAP. Try to do something and try to reduce his left atrial pressure. You wouldn't like to come off while his LAP is raised. Or if at least see if it was S was very depressed previously and now it has come up. Fine, which I have showed you in one of the slides. So pulmonary vein addressing is very important during surgery. Even Prasanna had told us, Murlidhar, if you remember, that he comes off when pulmonary vein, this thing is normal.
Yeah.
Low profile is normal. So this pulmonary vein gives you immediate idea about the LAP. Instead of E prime, instead of E, which are load dependent and they are changing. So S and D ratio of pulmonary vein is very sensitive also and useful also.
Any final comments, Puneeth and Arun? Then we'll close it. We are.
And another
approaching.
important point, which because of lack of time, I have not explained, that feeling pressure is a very general term they are using. It means LV or LA pressure in diastole. It can be mean LA pressure, it can be LVDP, it can be mean LV pressure in diastole, and they are different by few millimeters, 1 or 2. And
Yes.
normally, so that is why that curve is very important. You just remember that curve, how beautifully it goes up during and diastole. So, and how LAP goes beyond that, and then everything becomes haywire, and then there is no correlation.
Rightly pointed out. The lowest LA pressure is different from the pre-A pressure and
Yes,
actual
pre pressure
LVEDP
is
and the actual LVEDP. So all the three are slightly different, but should not be confused that the LAP means a single entity. It's a combination of all this. With that, I would like to conclude the session. Thank you, Dr. Sanjeevani, for that excellent presentation. We are indeed grateful to you for joining us. And I would like to thank Arun and Dr. Puneeth for joining us, and all the others who are in the meeting. Thank you so much. We would look forward to having you again for the next Sunday for another topic. And with that, I would like to conclude this session and ask Rimpa to play the IACTA TEV video. Thank you so much.
Sure.
Thank you.
Thank you, sir, for the opportunity.
Thank you for the opportunity, sir.
Thank you. Thank you.
So, thank you so much, everyone, for joining this session. Clarinet is really glad to have all these brilliant people together. So, with all your permission, shall we conclude the session for today, sir?
Yes, yes, please.
Yeah. So, thank you so
Thank you.
much. With all your permission, I'm concluding the session for today and looking forward to hosting you again. Thank you so much, everyone. Have a great day.
Thank you. Thank you.
Thank you. Thank you. Thank you, Murli.